Everyone, it is Friday, November 14th. This is another Florida EMS webinar brought to you by the Florida chapter of the NAEMSP. Again, it's an organization that includes not just physicians, but professional members, EMS leaders. So if you're a medical director out there, please bring your EMS leaders with you to the conference, especially it's in Florida this year, and there's no reason not to do that. So let's get to the business of the day. Today, we're actually going to get into one of the most consequential and maybe one of the most emotionally charged topics in modern pre-hospital trauma care, which is the role of spinal motion restriction and cervical collars when you suspect spinal cord injury. So many of you know that we have spent over 50 years anchoring ourselves to the belief that restricting spinal motion prevents secondary neurologic injury. However, our speakers today may tell you differently. So today, we're very blessed to have the first author of the paper, Dr. Michael Millin. Many of you know Dr. Millin. He's an ED doc at Johns Hopkins, been faculty there for a long time. He's a thought leader in EMS, and he's one of the principal architects of this trauma compendium. This next guy needs no introduction. He's one of our own, Dr. Ben 𝘗𝘳𝘦𝘩𝘚, EMS physician. He's with a number of organizations, EMS organizations across the state. He's a national speaker. I called him the other day when we had a snake bite in Brevard County, and he answered the call as he always does. So without any further ado, Michael and Ben, welcome. I'll turn it over to you, Michael, first for any further intros, and Ben, and then please feel free to share your slides. Take it away.
Awesome. Well, thank you so much, Peter, for inviting us. It is absolutely thrilling to be here with everyone today to talk about this topic. I'll also mention that I'm a past chair of the NAEMSP Standards and Clinical Practice Committee. I got involved with S&P when I was a fellow a little over 30 years ago. I can't believe it's that long. So I've been really interested in evidence-based practice medicine and developing clinical practice guidelines for the practice of EMS for quite a while. I was involved in writing the 2013 and 2014 paper on backboards that was led by 𝘗𝘳𝘢𝘕 White. At the time, I was the chair of the S&P committee when that went through, and so I've been interested in this topic for quite a while. So we're going to get into this. I know we're time limited, so I don't want to talk too much. I'll let Ben give any more introduction he wants to give as I'm pulling up the slides.
Hi, I'm Ben still. It's good to see you all. This is, as Michael's pulling it up, I just want to say, of all the things that I've been involved with regards to S&P and everything, I think this honestly has been the most rigorous scientifically, and Michael is a great leader for this. And let's dive into it.
All right. So the title of our presentation is Delayed Spinal Cord Injury: Untethering the Dogma, an Evidence-Based Approach. And hopefully you'll see that it really is part of what we're going to do is challenge what has been dogma in medicine. We are going to start our story, oddly enough, with George Washington. So in 1799, George Washington was dying of epiglottis and sepsis. His doctor's blood let him, and he died. You might wonder how this is relevant to the work of spinal motion restriction, and it really is relevant because it tells the story of change in practice in medicine. And when we learn new information, we should absorb that and be willing to take that into account, especially if we learn that what we are doing is causing harm and there's no evidence of an equal or greater benefit. So we'll start with a little case. So we got a 45-year-old male. He's mountain biking. He flies over the handlebars. I should also note that my current practice, I'm the medical director for a wilderness EMS agency in Maryland called Austere Medical Professionals. This is actually a real kind of case that I would take care of in my practice. So a mountain biker flies over handlebars, lands on his shoulder, he's complaining of pain in his shoulder, developing some numbness in his hands. He's not right next to a road, and so clinicians come, rescue him, walk him to an ambulance by the road. As he's walking to the road, he develops some numbness in his hands. He eventually loses grip strength in his hands. I'll note his vital signs there, which we'll talk about a little bit later. He gets to a hospital, and he's found to have central cord syndrome. So the question that really is before us is, if the patient had a cervical collar on, would that make a difference? As well as, are there other things we should be doing with the care of this patient besides just trying to immobilize his neck, which really is kind of how we've approached the care of these patients for so long. Come across them, the first thing you do after recognizing their airways intact is put a collar on. So the Congress of Neurological Surgeons tells us that a rigid collar and backboard is effective in limiting motion of the cervical spine and is recommended. They have two references that support this statement. Paper by Toscano, published in 1988. We're going to get into that paper in a little bit. And they say time-tested clinical experience. That is really what is supporting our practice here, is time-tested clinical experience. If you read the paper by Dr. Theodore, that is exactly what he says. That's a direct quote, as the importance of doing this is time-tested clinical experience. In 2018, American College of Emergency Physicians with American College Surgeons Committee on Trauma and NAEMSP writes, a cervical collar is a critical component of spinal motion restriction and should be used to limit movement of the cervical spine. So essentially, our practice, our professional society is establishing that the use of cervical collars is standard, and this is what we should be doing. The references they use to support this statement are zero. When you go to the 2018 paper, there are no references that support that statement. And so essentially what you have is establishment of practice here using no references, and so therefore is just expert opinion. So how do we get there? Well, there's a lot of history. Due to the time, we're not going to really get into that history. You can read that through our paper. Just note there's a lot of history, and all that history is really case reports. There's really nothing besides case reports. We wanted to mention these three papers. Really nice photos they include showing pulling patients out onto a backboard with a pulley and winch. They're really fun papers to look at, but they're essentially editorial papers and educational papers. No patient data in these papers. We then fast forward to 1971 and the publication of what is often referenced as the Orange Book. It's the first EMS textbook published by American Academy of Orthopedic Surgeons. And there they write, if the head of an individual with a broken neck is allowed to move, the motion may contribute to paralysis or death. And we all know that once it's written in a textbook, it is now standard of care. And so standard of care was established based off of case reports and these fun pictures. So that gets to our paper, which was a scientific review within the Trauma Compendium series. As Ben said, it was really our goal to put together a project that you really can't put holes into. Certainly, there's no perfect project. There are flaws to our project, as there would be any academic project. But my goal was to put together a project that was tight as possible and the methods as strong as possible. And so this was developed through the Trauma Compendium series. I would give a shout out to Dr. Krishna Martingale, who was instrumental in helping us formulate this and develop the search strategy. I owe a lot to him in the early development of this paper. Here's our methods. And so our search strategy was based on this PICO question, and our null hypothesis was that spinal mobilization has a clinical benefit. It is important to note that when we went into this, we assumed that because it was standard of care, that it had to have a benefit and there was a scientific basis to that. Our alternate hypothesis is care of the patient without immobilization. So there are four questions, and the first one really is frankly the most important, and that's with underlying pathophysiology disease. Everything we do in medicine should be predicated on understanding a pathophysiology disease. If there's no pathophys demonstrating that delayed neurological injury can be caused by post-injury movement, then there's no reason to be immobilizing. And so what is the underlying pathophysiology disease? The next questions are, does cervical collars have a harm? Do they have a benefit? And note that we flipped the script. We believe that we should be thinking about harms before we think about benefits. Are there harms to the procedure we're doing? We know that everything we do in medicine has the potential to have harm. If we're going to hurt our patient, we should expect an equal or greater benefit. And so then what are the benefits to immobilization procedures? And there are really two questions in there. One, are they effective at limiting motion? And two, are they effective at preventing neurological injury? And then there are other factors. Really specifically, we're interested in pediatric patients and geriatric patients. There are 4 professional societies that were involved: National Association of EMS Physicians, American College of Emergency Physicians, American Academy of Pediatrics, American College of Surgery Committee on Trauma. This is not an approved position of those 4 professional societies, but we'll note that they were all actually involved, and all the professional societies reviewed early drafts of the paper, gave us comments, and those reflect in the final draft of the paper. You can see our process we used was initially for title and abstract review with single reviewers, and then when we got into full manuscripts, it was a double reviewer. And then I would also note there were hand search involved, which we'll get into. So you can see we searched 4 different databases, 3 different times to increase our validity. And again, we had a hand search. So if our review didn't capture it through the actual search criteria, we had a process to bring in articles that an author might know about through a hand search. And that's partly also we went to the professional societies. We specifically asked all professional societies, including American College of Surgeons, if there were papers that they knew of that could be the smoking gun that might not have been captured in a review. That's the reason we had that hand search in there. We searched just under 4,000 manuscripts. It was obviously a very big review. It dated back to 1900. And the reason we did that, again, was to try and capture that pathophysical disease. We then divided our reviews, articles we found, into those 4 questions. So the first thing on the pathophys to note, there are 2 articles that point towards post-injury movement. They were both published before MRI technology was ubiquitous in the practice of emergency medicine, and they're both case series. Again, we're going to talk about 𝘗𝘳𝘦𝘩𝘗 specifically in a second. And all the other papers really point towards hypoperfusion. These are all papers published after the development of MRI technology. This is really an important thing to note in that when spinal motion restriction was started, we were treating the bones. And what we really care about is the spinal cord itself. And so I'm interested in the pathophysiology of disease of the spinal cord. And there I really need to use MRI technology. When you do that, you show that it's really mostly about perfusion. I do want to talk briefly about 𝘗𝘗𝘦𝘩𝘗. 𝘗𝘗𝘦 is a very interesting paper. This was done by someone who was in their last year of surgical fellowship in Australia, where he basically traveled around Australia to different hospitals and did interviews of the staff in hospitals, looked at patient charts, and retrospectively then tried to figure out what could be going on that landed patients in the ICU. There were 9 patients that he found where he determined that neurological deterioration occurred during the management of EMS care. We don't have any data about those 9 patients. He provides data for 2 patients who developed neurological injury in the operating room while getting a repair of aortic arch injury. He writes that suspicion of possibility of spinal cord injury followed by appropriate handling and mobilization could make major neurological deterioration a rare event. So based on his review, he made an assumption that post-injury movement could be the cause of delayed neurological injury and noted if we pay more attention to that, then we could prevent neurological injury. But he also writes that it's difficult to ascertain if the deterioration is due to natural disease versus inappropriate handling. And so even there, authors recognize that maybe we could be wrong and it could have nothing to do with post-injury movement and something else. We would then note some papers that look at the pathophys of hypoperfusion. There are really 2 that are most interesting. This is one of them, where they basically looked at episodes of poor perfusion in 3 different settings, in the pre-hospital setting, in the operating room, and the intensive care unit. And they showed if you have less episodes of hypoperfusion in the pre-hospital care environment, you have less neurological injury. And we hone in on a mean arterial pressure of 80. The other article hones in on mean arterial pressure of 85. This is an important thing to note in that these are retrospective studies. We don't have any prospective studies on this question. And so therefore, we actually don't know for sure the mean arterial pressure of concern. but certainly it's higher than the 65 that we probably are having our clinicians pay attention to most of the time. There's a whole host of harms related to spinal motion restriction. We divided this out kind of in relation to the practice guidelines been published. So before the first guideline was published in 2013, and then in the interim years between 2013 and the 2018 practice guideline, and then after the 2018 practice guideline. We did that to show that the longer clinical societies wait to make a statement that this is harmful, the more harm is going to happen. And ultimately, it's on the clinical practice, it's on the professional societies to actually finally make a statement. The longer they do it, the longer it takes for NAEMSP to make a statement, the more they're condoning harm. And so that's the reason we just divided out these years. We're going to get into a couple of these. We don't have time to get into all these, but obviously there's a lot of harm that we found. So the first one we want to note is paper by Worsley in 2018. This is a prospective study, 15 volunteers. It is a volunteer study, but nevertheless, it notes that the development of decubitus ulcers happens immediately. I've often heard, oh, it's okay to put a collar on for a while. We know it causes harm and development of decubitus ulcers, but that doesn't happen until they're in intensive care unit. And that's just false. Decubitus ulcers start to form immediately. That is an immediate harm. It is not a delayed harm. And the other one to note is this paper by Jarvis. This was a paper specifically about a geriatric population where you had patients who were collared, those who weren't collared. Those who were collared had increased risk of dysphagia and airway compromise. We've often heard things like, okay, we're going to soften it in the low-risk patients, but those older patients, they're at higher risk. We should put a collar on those. And no. Those are actually the patients that are at the highest risk of harm from collars. And the patients that I don't want to be collared are the geriatric patients because collars cause them to lose their airway. So then we looked at the effectiveness. You can see on the column limits movement, quite obviously, if you strap a patient to a backboard hard enough, they're not going to move. We know that in the literature. That's common sense. You put a ton of bricks on someone, they're not going to move. Of course, they might not also breathe, but we can limit movement. If we then study, okay, I want to allow them to breathe and actually be a human being, then what we show is there is increased movement of the spinal column. And there are really interesting couple studies where it shows that actually that increased movement is specific at the C7T1 junction. So where the collar meets the sternum, it becomes a fulcrum point. And so all that collar is doing is actually increase movement at an area that actually specifically is at high risk for injury at the C7T1 junction. There are two studies that looked at this. One where they put a patient on a vibration board, and the other where they put the patient in a moving ambulance. And this one, the moving ambulance, showed that the collar did not prevent movement when you start moving the patient in the ambulance, and it actually increases movement at that junction. So then we looked at the effectiveness of preventing injury. There are a couple studies that are interesting that suggest potentially it might actually increase the risk of injury, but you'll note there's no studies that prevent neurological injury. We'll note that again, and Ben wanted to really note it again by making sure you paid attention to the fact that there are no studies that show that spinal motion restriction prevents neurological injury. So again, we'll note lots of harms. We note the pathophysiology of disease shows it's really about perfusion. And we note that it doesn't prevent injury. And there are two articles here that we're going to mention. The first is a paper by Chen, published in 2022, and the second is the paper by 𝘗𝘳𝘦𝘩𝘗𝘓 in 2021. So
again,
by Chen,
no proof it protects. Go on.
Yeah. So the paper by Chen is interesting in that this is a study done from a trauma registry. And in a post hoc analysis, subgroup analysis, they showed that the use of a cervical collar could prevent injury. However, this paper has some significant flaws that we would mention. The first, you'll show that patients who are given pre-hospital fluid have increased risk of injury. And that we think is a surrogate marker, therefore, for patients who are hypoperfusion. So hypoperfused patients are actually the ones that probably have the injury, and it probably has nothing to do with their have a cervical collar on.
This article really highlights, a lot of people talk about RCTs at being at the top. This is what we did was such a strict systematic analysis of the articles. This right here is a great example of why you can't just read an abstract. You can't just read a conclusion. You can't read a fancy Facebook funny meme. You have to actually analyze what's going on in the paper, because they concluded one thing when really it's like, where are you getting this idea from? Here's some thin air. So it's really important to realize that this is the kind of stuff where we really need to have this in-depth look at the science. And one of the things that I want to give Michael credit for is we actually all signed an attestation from all representatives of each society, including the surgeons and all, that we're going to try and check our biases at the door, to try to prove those questions. We're not trying to just disprove collars. We're trying to look at the science to answer those questions. And it was so in-depth to actually look at these, every single article, as hard as we did.
So the Chen paper is important because there's fatal flaws. And frankly, if I was a reviewer of this paper, I wouldn't have gotten it through publication. So as I mentioned, patients who are given fluid have a worse outcome, but most importantly was their definition of a favorable outcome, which include a modified Rankin score of 3. And so patients who are unable to walk without assistance are the patients who they decided had a favorable outcome. And personally, I don't think that's a favorable outcome. And so if you took that out, and the common definition of a favorable outcome in the literature is a modified Rankin score to 0 to 2, not 0 to 3. And so if you were to define it the way it's typically defined in the literature, that would likely close the gap on that p-value, and it would no longer be statistically significant. This is a fatal flaw of this paper. This is why you have to actually delve into the literature and look at the numbers. The other paper we would note, the paper by 𝘗𝘳𝘠, is very interesting in that in this paper, there were 3 patients who developed neurological deterioration. All 3 patients were actually wearing a cervical collar. So we flew through that. There's a lot of meat to this paper. Essentially, we cannot prove that post-injury is not a cause of delayed neurological injury. That is important to note. We can't disprove it. But frankly, from a scientific process, we shouldn't have to prove it. The way the scientific method is supposed to work is you develop a hypothesis and then you test it to see if it's true. The scientific process here was thwarted. We went from case report to a standard of care, and no one ever proved that hypothesis to be true. We don't have to disprove it. Someone else needs to prove it. There's greater strength in the literature supporting hypoperfusion as a cause. Again, we don't actually know the real blood pressure value, but it's probably a mean arterial pressure somewhere around 80 to 85. There certainly is literature that shows restriction of movement, but there's also literature that shows that SMR does not do that and actually can increase movement. And obviously, there's no literature that we show demonstrating there is prevention of neurological deterioration. We would note on our case, the fine point on the vital signs, that this patient had a mean arterial pressure of 80. And obviously, when I developed this case, there was to hone in on that maybe what we should be paying attention to is perfusion as opposed to something. So would a cervical collar help? We don't think so. Should we give fluids? That's a really great question that we don't know the answer to. That's right for research. Should we give vasopressors? We don't know the answer to that. That's also right for research. Should we carry him out as opposed to walk out? That really gets to the perfusion question and making sure we're maintaining a mean arterial pressure somewhere around 80 while perfusing the brain. We would say focus on resuscitation, focus on patient comfort. And I'll let Ben finish up the last couple slides here because these are his, and I think hone in on the point really well.
So we've been doing these practices for years. A number of us have been doing EMS since the 1900s, right? And in theory, we immobilize, and immobilization is also SMR's restriction. We immobilize and restrict to prevent secondary cord injury. We do it to prevent making potential lesions larger or worse. And we do it to not manipulate unstable fractures to maybe cause a cord lesion. And all this is BS. Go ahead, click to the next. The reality is we do this crap based on tradition, on dogma, the fear of litigation that's completely unfounded. Can't find a case that set precedents of this. It's been indoctrinated into us, and because we are afraid of the people who refuse to practice up-to-date science-driven medicine. We're afraid of the neurosurgeons. We're afraid of the trauma surgeons. We're afraid of the ER nurses or the doc saying something. This is the reality of why we immobilize and restrict, and quite frankly, it's not right. Going to the next slide there.
Yep.
The big take home, we say in overall, backboards and cervical collars, they're cancer. They are cancerous, right? Like cancer, the concept that they help has spread out of control and they've invaded the minds of clinicians. As Michael pointed out, we did this in-depth dive with multiple societies that took place in all this. There is zero biological basis in the disease. It's a made-up concept. There's no scientific basis that there is actual benefit out of doing this. There's no scientific basis that post-injury movement causes delayed neurodeficit, and there haven't been any legal cases setting precedents for increased liability. And quite frankly, it's at the point where if anyone wants to say otherwise, as Dr. Miller said online and stuff, they need to present the actual science to support said belief. But right now, Michael and I, we believe that for our practices, it's unethical to use these devices. And the other thing that as we're doing all this data extraction and talks, and this as we were developing it, I coined the term iatrogenic distracting injuries. And what that is we're so busy doing something, trying to help. It's good intentions, but it's trying to help, and it's actually taking away from other things that we need to do, like resuscitate the patient or airway management or treat the pain or treat the psyche. I've completely removed it in Escambia County from all practices. My neurosurgeons are 100% on board. There's a little delay from some of the others, but they were worried about what the neurosurgeons would say, and we support each other in the practice of our medicine. Again, I think that to do it it's like giving a paralytic without a sedative or pain medicine. It's accidental. We have good intentions, but it's actually harming and unethical.
All right, we flew through a lot of material. I'm going to stop the share screen. Does that sound about right? I'll stop the share screen. I'm
Perfect.
sure there's lots of questions. I'm not
Oh
sure
yeah.
you have.
Oh yeah.
I also will just quick note for 10 seconds. Entire states are quickly following suit with this. And this is, as Michael said, it's not a position statement yet. This is a resource document that's being used so that we have this discussion.
All right. Awesome. Listen, I'm so excited for this conversation. For those of you who are going to head over to Dr. Pepe's webinar, go ahead. We're sticking around here as long as Michael and Ben will, because we want to get to a lot of the questions and many comments. So first of all, thank you guys so much for taking the time to actually go through the literature, put it all on paper, because and Charlie and I and Paul, we were at a meeting yesterday, our Chiefs meeting, and Charlie brought it up, Dr. Ingham brought it up, and there were already people standing up at the microphone saying, but what about this, but what about that? And so I want to bring up a few of the buts, which you guys have already covered, but just because I want to make sure, and I see Carrie Bachisa just asked the same question, but and Michael, you mentioned it earlier that the surgeons and ACEP were involved in the paper, but do you see any barriers? Did you anticipate any barriers in achieving a cross-organization alignment? So how about we start with that one first, because it'll roll into some of the other questions I have.
Yeah, absolutely. It's a great question. There were a lot of conversations, right? And a lot of politics involved. And the higher ups in the organizations are looking at things from the 60,000-foot view of not just this topic, but how do decisions they make on a board level affect everything else they're doing in the association. And so if it was just about this topic, NAEMSP board of directors would be on board entirely, a position would pass instantaneously. I do know definitively that 𝘗𝘳𝘬𝘱𝘪 is totally in line with what we're doing, and he believes. But as president of the association, he has to think about not just this topic, but other things they're working on. And so it's going to be a process. I know that Doug is hoping to bring together his counterparts in the organizations and have conversations. I'm hopeful that that'll go positively. Could I see roadblocks and barriers? Absolutely. Not because of the science, but because of politics.
I'll say too that immediately, so I'm about to be recording a podcast with Prodigy for NAMSP at the request of Dr. Kupis with Doug Wolfberg and some others. And then also we're looking to present at me with my trauma surgeons and neurosurgery and stuff at ACSCOT in March. Again,
Okay.
this is the goal is to do this jointly. We needed to have some of the science so we can drive this conversation.
I think the other thing to note is that as we said all along to ACSCOT, show us the science, right? It is possible I'm wrong. I could be wrong. Show me the science.
Mm-hmm.
If they have science that demonstrates the spinal motion restriction prevents neurological injury, show it to me. And if not, then stop roadblocking.
Yes, yes. I mean, you guys are, I think, doing it the right way, and I love the next steps that you guys have laid out. So thanks for answering that question. I'm gonna hog the microphone for a few more minutes here. So the next question, which is going to come up, it's come up every time I bring this up to people, which is, you have a patient who's GCS of 3, after the fall over the bike, etc. They have no tone, and you now have them. You get a scoop stretcher, you put them on the stretcher. What do you do with that person's neck is really the question. Anything, or do you put some head blocks, do you put some towel rolls, do you do a soft collar? Like what are your thoughts about that particular patient?
Okay, Ben and I probably have, we both have an answer to this that is similar, but I'm going to have Ben answer that first.
So whatever you need to do, we're not just taking them and throwing them on the stretcher. We are, if they're conscious, they don't have the GCS of 3, like you just said, they're protecting themselves. Science has proven that. WMS, other countries have been proving that they're fine. For that obtunded patient, it's mostly treating the practitioner, the clinician, right? So I'll allow rolled towels on either side to help a little bit, just to support. But in reality, the head's not moving much for it, and we need to be able to concentrate on what's going on. What I don't want, though, is the towel roll or the head blocks and then strap on top, where you're just, creating that bigger fulcrum, just like the collar is doing. So I'll support on either side of it, but not completely secure it down.
So what I would add to that is we're not saying don't do anything.
Okay.
We're not saying just throw your patient around like a sack of potatoes and hurt them. No, we're saying treat your patient carefully and with compassion and keep them comfortable. I'm a wilderness EMS guy. I take care of patients deep in the woods, and we're getting patients out on a Stokes stretcher. And so we lift a patient off the ground. We use a blue tarp. We roll the patient onto a blue tarp, lift the blue tarp into the stroke stretcher, pad their necks softly with some towels or something, and then carry them out. It's easy to do. It's no big deal. I'm treating my patient with compassion and comfort. It's not that I'm doing nothing. I'm just changing what I'm doing.
Perfect. Great answers. Now, for my last question before I go to Tanner, Ari, I'll get to you, I promise, is the one that I think is going to be the one that's going to be the hardest hump to get people over, even though they won't say it to you explicitly. And it's the medical legal one, which you guys addressed. And I can tell you that, I've been practicing medicine for 25 years. I've only ever been sued once, and that was as an EMS medical director. It was total bogus, right? They had, our medics did nothing wrong, but we had a big policy, so they came after us. Years and years go by, and they find doctors that you know, if I said the name, you would know who those doctors are. They came up against me to get paid, right? Now I ended up getting released from the lawsuit because it was total bogus. But there are physicians out there, guys, you know that, who will come and say things because they're going to get paid the 500, 600 bucks an hour. So how do you overcome this concern, the medical legal concern that the fire chiefs, the EMS chiefs are going to come, the legal folks at the city are going to come and ask you about, even though there's none of this stuff, we're not going to have a PowerPoint in front of 12 jury members. What do you think?
So a couple of things with that. Number one, I go back to I worked on the largest tort claims research article project with Henry Wang, where we went to and I abstracted all this data from McNeil and Company, which is a huge insurer, and we looked at all insurance claims for EMS under the McNeil umbrella, which they were the largest insurer for fire and EMS in the U.S. And we were looking for where we actually lost money, whether it's a settlement or went to court or anything like that. Is it the landmark airway case? Is it the landmark neurospinal kind of thing? And couldn't find any. Didn't find any regarding the spinal stuff. And I've served as for a number of cases as a legal expert, as an expert witness, and I easily have that case. Not to mention, you know, I've had for four of the firms that I've done expert witnessing for, I waived some part of my fees because I wanted to use their legal people to help me find any cases that set precedents. They've never been able to, and so far, talking with Doug Wolfberg, again, even as recent as last night, he hasn't been able to find any yet. So I think that the reality is we can't fear. It's like asking a girl out. Like I can't. Like I have to try to ask, right? If I don't ask, I can't have that fear of which is going to lead to rejection. I need to go ahead and go forth and do it. Don't let the fear happen. But it'd be easy to kind of disprove otherwise because we've got actual science, not hearsay.
Great
So
points. Michael?
I've also been sued once in my career. I got sued in my 12th year of emergency medicine practice. I met with my attorney who said, wow, you've never been sued before. You must be an amazing physician. And so that just highlights that this is part of the practice of medicine, is there is a legal environment that we operate in. When I got sued, it actually had nothing to do with what I did. It was connected to a case where the orthopedic surgeon who treated my patient like a jerk. When you look at the literature, the number one reason people get sued is because the clinician was a jerk. It's not because of what we do, it's because of how we treat our patient. Treat your patient with kindness and respect. Use evidence-based medicine to hang on what you do. And you get sued, I'd be thrilled to be your expert witness because there is no science to support spinal motion restriction. Standard of care is established in the courtroom. It's time we reestablish standard of care. I'd be thrilled to be the expert witness on this case. I hope you don't get sued because it was a horrible experience when I got sued, but it is part of what we do. And if it happens to you, I'll be there to support you.
Well, I appreciate that. And before I move over to Tanner, I will tell you that I'm glad that the association put out a document about expert witness because there are people out there and they're practicing around us, all around us today in EMS who will take the cash and spew out nonsense. And I've actually been given a restriction that I cannot mention this person's name because they were so worried that people will go and find their deposition, which was a horror. Let me go to almost Dr. Tanner Smeeta. So Tanner, you've been listening and very intently here. You are not just a student of the research, but you've written many publications. Let's hear your thoughts.
Yeah, so from a research perspective, I do see a lot of opportunity here, right? So it seems, you know, we're taught in medical school that the way we're supposed to implement, you know, new therapies is through kind of a series of clinical trials, right? You have phase 1, phase 2, phase 3, where you really establish efficacy. But people often don't talk as much about the phase 4 trials, right? Which is kind of ongoing monitoring of the risk-benefit relationship out there in the real world. outside the context of a trial. And it seems like, right, for spinal motion restriction, they skipped all the trials altogether, just rolled it out in the real world, and now we're stuck. We can only do phase 4 evaluations. And so I think there's huge opportunity here as states move in this direction, and as people kind of remove this from the scope of practice and do a lot less spinal motion restriction. I do think there's a huge opportunity to continue ongoing monitoring and surveillance to ensure the safety of this practice and continue to shore up the evidence base to support this decision moving forward. And so the question I would ask our guests is, it's very difficult to do trauma research, especially with trauma registries, because of how heterogeneous the patient population is, right? Of all of the trauma patients that we see, very few are going to actually have clinically significant cervical spine injuries. Even fewer of those are going to have unstable injuries that could even be impacted by spinal motion restriction. And so I would ask you, if the West Virginia state trauma system, if we made this change on a statewide level and we had to pick a patient population to monitor, what would that population be? Whether that's an ICD-10 code, some specific radiographic finding, is there one that you would be able to pick?
I think that my first gut instinct is why pick. I feel strongly enough about this that, like I said, we pulled it off our trucks. We know the hard date of when I first went very restricted. It has to be a properly sized collar, only certain things, as long as they're not moving more, otherwise remove it. And then I have a hard stop date of when we threw out the collars, which, fun fact, cervical collars fit in both urban and rural dumpsters, just so you know. But why not do it something like a case control series where, because we have the data of all ages and all pathologies and all ICD codes from before, we can then look at all of them so that we don't have those limitations. That's my initial thought out of it, and that's what I'm trying to actually set up and welcome others that have similar registries and kind of stuff to do. I don't know if you as a stronger researcher than I have any thoughts on that, but I wouldn't see why limit it.
Yeah, so I think this is an excellent question. I would point out when we started, so first of all, actually, we posted our methods on Open Science Framework. I posted them in 2023, and I did that specifically to help bring validity to our project. You can go read our methods that were posted in 2023. You'll see that our original plan was to do a meta-analysis of the literature. That was actually what I was hoping to do. And we discovered, as you correctly point out, this literature is so heterogeneous, there really was no way to do a meta-analysis without making phony numbers. And so what you're pointing out is an excellent thing to point out in terms of the scientific basis and how research is done. I would say that going forward, the way to study this is, as Ben pointed out, make some changes, keep track of those, and then retrospectively compare that to the past. And then that's a way to study. There are also some really interesting prospective questions that I think would be valuable to study. For example, what is the best mean arterial pressure for the management of our patients? That's right for someone who has the interest in doing that kind of research.
Yeah, thank you. And I don't want to take up too much time. I see there's a lot of raised hands, but I will say so. There are some other organizations like EAST, the Eastern Association for the Surgery of Trauma, and some of these other big groups that, as part of their organization, they host multi-center trials. And so, the organization will come up with a question, and then they'll have hospital systems, EMS agencies, all get together and say, we're all interested in answering this one question. Let's all contribute data. I wonder, not just for this question, right, but for a bunch of questions, if through NAEMSP, we could take 5 or 6 or 7 big systems that are all making this change at a specific date and do a before and after, with a lot more power and kind of a prospective manner.
I would agree that really is the best way to do it. I'm also glad you mentioned EAST. When we started this project, I actually petitioned NAEMSP to partner with EAST on this project. I was told no, that we had to bring ACS-COT into the picture instead. Obviously, that was all about politics, but I agree entirely with what you're saying about EAST in terms of the work they're doing. And I would absolutely agree that it'd be fantastic for NAEMSP to partner with EAST.
Excellent. All right. Tanner, any other questions?
That's it for me.
Okay, awesome. Let's go to Ari Eisenberg. Ari, thanks for your patience, my friend. Take it away.
No, So I actually wrote my paramedic thesis back in 1997 on this very topic. I'm a wilderness well, my wilderness cert's expired, but I was a wilderness paramedic in got my wilderness cert's in 92, taught a little wilderness, was also a lifeguard instructor trainer. So this is a topic that I have a little bit of experience and passion about, actually. And in my paramedic thesis, I basically came to the conclusion that if we put someone on a backboard, 20 minutes later, they will have back pain. That's proven. But what we also found was that the vast majority of people did not know how to properly immobilize a patient. 3 straps didn't do it. A 4th strap would reduce movement by 30%. Those who were trained in the wilderness world were much more adept at proper immobilization with padding and stuff like that, which I'm sure the doc could attest to in the wilderness world. So the question I have, and I've never been able to really get a solid answer, and I don't know if we ever will, is a few things. One, I think there may be a survivor bias involved here, because who was getting this treatment may be people who already had injury, so they qualified for spinal immobilization. Through spinal immobilization, I'm talking about. So I wonder about a bias, a survivor bias issue in that sense. But the only device that I ever really saw that would really properly immobilize a spine, besides the wilderness, the Stokes with proper padding, was a vacuum mattress, which never really came into use. So the question that I've always had, and I'm not disagreeing with where we are today that we don't have proof to justify spinal immobilization, but the question I always had was, if we were properly training people, like we talked about last week on the Lucas device, if people were properly trained in using vacuum mattresses, would the past information that we have be different than what we do have based on improper backboarding, which, as far as I'm concerned, is meaningless. It's like you did nothing on a backboard if they're sliding all over the backboard in the back of the truck.
We kind of
But
already. Yeah, sorry, go ahead.
No, so that's really my question is, if we were properly immobilizing people, would we have other data that supported it?
I think the answer is no. We already answered that respectfully. The fact of the matter is the restriction of movement and stuff doesn't do what it's even what we thought it did. It's not actually protecting the spinal cord. And the fact of the matter is, if we have a device or a practice in medicine, if we can't train to get it right, if it's that difficult, should we be doing that? So and again, I think that we already say, like, we've already disproven the concept that immobilizing, restricting movement helps.
So
okay.
Ari,
I'm not arguing. I was just posing the,
Yeah.
based on the
Michael.
experience and question. The other thing I want to just throw out.
Wait,
I'm sorry, Doc.
Ari, hold on. Ari, hold on. Let's go to Dr. Millin.
Yeah, so Ari, thank you for the question. It's a great question. There were 2 things I would point out to your question. First, again, to the underlying pathophysiology disease, we have no evidence that post-injury movement actually leads to delayed neurological injury. So that's the first thing. And the second thing I would point out is that we have evidence that vacuum splints themselves also cause decubitus ulcers and also restrict the respiratory system and make it difficult for someone to breathe. And so a vacuum splint, when applied correctly, as you're describing, has harms associated with it. They are not benign devices. Now, if they had a benefit, then we would say, okay, maybe the benefit outweighs the harm. But right now, without seeing a benefit to a vacuum splint, all we show is harms.
Gotcha. When are you gentlemen going to approach the various lifeguarding organizations and get them off the mantra of we have to backboard everything and anything? And they can backboard even worse than most EMTs can. So, I mean, that's, The
answer is yes. There is a long process to this whole thing. We would never expect change to happen overnight. but there are many different elements to this project. We are not done with what we are doing.
Michael and Ben, I see you at every YMCA across the country. Dr. Charlie Sand.
That's actually real quick. That's actually already done. We no longer. I don't know if you're still certified as a lifeguard. I still am. It was taken out a number of years ago. We don't do collars. The board is for extrication out of the water, and then you turn over to EMS. And actually, in the American Red Cross, USLA, and the Starguard Wilderness Lifeguard don't have full body immobilization anymore. That's
Okay, they finally took it out. Okay, last time I did a lifeguard class, they were still no collar unless you were, an EMS person, then you could collar, but everybody else was doing no collar, but still immobilizing. So in theory,
2009,
in theory, we're pulling the backboard once we get them on a stretcher, is what you're saying.
That's exactly right. Yes. Okay.
Okay,
Ari,
good.
thank you so much for your questions. I'm going to keep moving the show along. So let's go to Dr. Charlie Sand.
Yeah, thanks.
Charlie, go ahead.
Yeah, thanks, Peter. First of all, wonderful lecture, wonderful discussion. This has been just incredible. You saw some of my comments, just so you know where I'm coming from, which I think some people do. By the way, Peter, this has gone as long as my advocacy talk on pre-hospital blood in September. But real quick, just to further on my comments, I did for some reason, I did a ton of stroke TPA defense work back in my day. And I would come in there and blow the plaintiff out of the water because I knew my stuff. You guys can do the same in this. So thank you, Mike, for offering that. You guys will blow the plaintiffs out of the water. And number two, I'll just say, if you saw my advocacy tape, my dad was a high-powered attorney in Miami, represented hospitals. He taught me a thing or two. You guys would win 99.9% of cases. Just saying. Thanks.
Great. That's great. Appreciate that comment, Dr. Sand.
Yep.
Chief Lou Steinberg, let's take your question. Oh my God.
I'm studying the efficacy of preventing whiplash injuries during online presentations. Seems to be helpful. So just a couple of points. In the 71 text, it actually does not reference collars at all. And that's the year I started. We never learned collars till later on. Even in the 66 text, the College of Surgeons was a little more drastic. They said if you allow the patient to lift their head, the injured spinal cord may be ground between parts of the broken spine, thereby destroying any useful remnant of the cord which may have escaped injury. But in between nothing and everything, we had soft collars. And my question to the docs, what are your feelings on soft collars, not for spinal immobilization? Hold on, I see you shaking your head, Dr. Abel. But as far as the whiplash injuries, limiting movement to prevent the pain, and the other, like someone all of a sudden, hey, you, and does that, they tended to prevent excessive movement and pain in the cervical region. Forget the spine for a minute. Any thoughts on that?
I think it's a great question. Our study was not powered to divide out stiff collars from soft collars. And when we look at them together, soft collars themselves have harms associated with them. And so I would be careful with soft collars. To your question on whiplash injury, I would consider that more of a muscular injury than anything else in reality. And so what's the best way to manage that? It's probably not necessarily collar. It's probably doing other things, but I'm not an expert in whiplash injury. I don't think we have the power from our data to answer that question. It's an interesting question. I've always thought of the soft collar as a comfort thing as opposed to anything else. If someone feels comfortable with it, okay, but I'm not convinced it doesn't cause harm.
And actually, I have some data for you guys on that, which I'm going to post right here. I actually asked the authors of this paper from Australia. I'm sure you guys know about it.
I was just typing this.
Right. So I emailed them yesterday. Unfortunately, it's Australia, and they both couldn't make it. But they had 1,762 patients included in their data set. And interestingly, there was no change or no difference in pressure sores. Both groups still had them. Hospital-acquired pneumonia, both groups still had them. And cervical spinal cord injury, both groups still had them. So we'd love to hear your comments both on that,
and this
on that paper.
That paper was a review. So they had a nationwide change of practice from they got rid of backboards and they got rid of hard collars, and then they went to in 2014 to consider soft collars. So this is, this is a whole series looking at that, which is pretty decent data for it, and looking through their data, and then recently discussing a number of things down there with the Aussies. And I'm actually going down there in the spring for some things to have further discussions about it, among other stuff. Their data, as pointed out, is that it's actually not beneficial.
Okay, excellent. All right, Ben, Michael, that's I'm glad that you guys kind of brought that comment up, because it's an important one to talk about. Because I, for one, I have to admit, I was thinking, let's boil this frog slowly. Let's let's get the soft collars, and then. But I'm what I'm hearing today. I'm really 100% behind what you guys are saying and all the data that you've put out. Ben, question for you and Michael, since guys, you've both been doing this for a while. I can only imagine that some of the medical directors on this call are thinking to themselves, what's going to happen here now is the same thing what happened when I try to pull away backboards and people got a lot upset. It takes months until you kind of make that happen. We took away 𝘗𝘕𝑚edrol and people got all upset, even though it has no benefit to the patient while we have them in the back of our ambulances. So my question for you all is, any recommendations on how to do this, kind of boil the frog slowly, or do you just come and say, we're taking this off, too bad, so sad? Any thoughts on that?
We both have thoughts, so like Ben, go first.
Yeah. So, and remember too, Michael and I are also from different states where, Michael has statewide protocols, and for us here in Florida, and there have been other places, a couple of places that minimized. As Dr. Landry knows, I didn't want to slow boil. I like to quick flash fry for things that I feel are right, and I think this is right for the flash fry. I had initial conversation. What I did in Escambia County was I had conversations with trauma surgery. I talked to the neurosurgeons. I said, here's what I want to do and why, and we had discussion. That's the important thing. Have the discussion. And then I kind of wrote things up, my summaries as to why, and I educated everybody to why I'm doing it, and said, this is what I'm doing. This is why. Do you have any questions? Let me know, because starting on this date, we are doing this. I support you for what you want to do, if you really want to. If you want to spend $394 on an Aspen collar or $192 on a Bregs, properly sized, once we deliver them to the hospital, that's your own prerogative. But my practice of medicine, I need to do what's right. So we can have the conversation now, but this is what's coming, because again, this is what's right. The most important thing is have the conversation.
Good answer.
So there are multiple parts to that question. The first part Ben alludes to, and there was a question by Ari in the chat about collars still being used post-surgery. So our paper, our project, my expertise is the practice of EMS medicine. I'm not going to tell a surgeon how to do their job. Similarly, I would have greatly appreciated if the surgeons stopped trying to tell me how to do my job. Until they decide to ride in the back of an ambulance and become board certified in the practice of EMS medicine, they need to stay away from trying to tell me how to do my job. And similarly, I'm very happy to respect them in what they're doing and not tell them how to do their job. So this is about the practice of EMS medicine. We then get to two parts to your question, which is the system-wide question and the direct patient care question. From a system-wide perspective, as Ben noted, in Maryland, we have statewide protocols. I can't just do whatever I want, change it, and then ask for permission. It doesn't work that way in Maryland. I actually have to ask for permission as opposed to forgiveness, excuse me. And so that's the way we do things. In the state of Maryland, we have a wilderness protocol that my agency operates under. In the wilderness protocols, there is no requirements for cervical collars. Because of our work environment, I was able to get that through the protocol committee. That has not yet happened in the statewide basis. That is a work in project. And I've told paramedics that I work with, most of my paramedics work both in the wilderness and in the street. When you're working in the street, follow your protocols. Don't get yourself in trouble. There's no reason to end up talking to a QI officer. This is a system-wide issue. Nevertheless, there's nothing that prevents you from making sure that your patient is well perfused. So go make sure your patient's well perfused while following your protocol. Now, if you're in a state that doesn't have that, then I would encourage medical directors to do the right thing and change your protocol because there really is no way to soften this. You know, if we try and do this by stepwide incrementation, which patient are we going to keep the cervical collar on where there's science to support that decision? There isn't a patient. And so if we're going to do this, we got to do it or recognize we're not going to follow science. And so at the medical director level where we're writing protocols or the system where we're writing protocols, it's time to make change because the science supports that.
Question for you then. In your current practice in the emergency department, you're in the ED, you're working a shift, they come in with you and the collar's on. Do you, Michael Millin and Ben Abo, just remove the collar and say, we're done, and then and maybe order some imaging, but are you even doing any kind of nexus? Are you doing anything like that? Nothing.
Instantaneously, so it used to be when I saw a patient roll in the emergency department on a backboard, if I was not in the middle of resuscitation with a different patient, I would immediately go over that patient and get them off the backboard. Hard stop, that would be my highest priority. Now, when someone rolls in, hard stop, I see a cervical collar on the patient, that collar comes off unless I'm in the middle of resuscitating another patient. These things are harmful. I'm going to minimize that harm. That doesn't mean I'm not concerned about a cervical cord injury. If I need to get a CT scan or an MRI or whatever, we're going to do that. And what I'm going to tell the patient in the interim is, while we're working on your imaging, do your best not to move your head around a lot. And believe me, they're thrilled to get a collar off. And they're going to say, sure, doc, I'll do what you need me to do. No big deal.
Excellent. Ben?
Same, it's immediately off. Even during residency, and a medical student, I was very quick I see them come in, even if it's not going to be my patient, I kind of do quick assessment, get them off the board. And back then I would replace the collar with a properly sized Aspen or Briggs and whatnot. And now I just immediately would take it off. If the patient hasn't already ripped it off.
Right. No, 100%. I agree with that. While I have him on, only because I see that he's making comments, so he's there. Dr. Ken 𝘗𝘳𝘢𝘭, our Deputy Secretary of Health for the state of Florida, the #2 guy. You made a great comment about plasma, which we are using for TBI. What are your thoughts here? You've been at the tip of the spear your entire career. Thoughts on this topic?
Well, as you know, I wholeheartedly agree in the uselessness of spinal motion restriction, which is why we got rid of backboards years ago, and why our protocol years ago even talks about how they don't have to use collars, but they should do something else purely for medical legal reasons. So I really appreciate what Ben, your work, and forgive me, I don't know the name of the other presenter there because I'm looking at my phone while I'm driving.
Michael.
Michael. This is absolutely fantastic, and it's landmark stuff. And it's amazing how hard we have to work to get rid of ridiculous ideas like mask pants, backboards, and now cervical collars, when these things were all put in place without really good clinical data to begin with. So what I suggest that we do is get the Florida chapter of NAEMSP or the Florida Association of EMS Medical Directors to make a statement that creates this as the standard of care for the state of Florida. We don't need the permission of the trauma surgeons, as you guys all spoke about already. That we have our own area of subspecialty expertise. This is within that realm. We just simply have to get together as an organization, state it, and be done with it, and move forward. There's no reason to continue. And as far as what Ben said, as far as the quick fry, yeah, rip the Band-Aid off, man. Why are we going to continue to harm our patients when the data is quite clear now that we're causing harm with no benefit? So I would say just do it immediately. Make the statement to cover everyone so they're comfortable from a medical legal standpoint that we agree as a subspecialty that this is the right way to go, and move forward.
Great comments. So as always, we'd like to give our speakers a last word. Ben, I'm going to start with you. Michael will finish with you. Give us your last word. And, Michael and Ben, I have a feeling you guys are going to get asked to speak around the country, maybe if not around the world. Reminds me of Sheldon Chesky's, who probably has like 1 million frequent flyer miles after double sequential. But Ben, give us your final comments, and then Michael will go to you to take us away.
EMS medicine is a practice of medicine. We need to always strive to do what's right. And we all, whether we're a surgeon, a physician, a paramedic, or an EMT, we have to have the humility to look at what we're doing, the why of what we're doing, and say, you know what? I might need to change what I'm doing. That's the biggest thing. And also, I am more than happy to, when it comes to this, I will come and advocate. I will be your free expert witness because this is important. This is important.
Thank you.
So again,
Michael.
thank you, Peter, for inviting us. This has really been a pleasure to speak to everyone. I'm thrilled to be here, and absolutely, I'm very committed to traveling the country, the world, whatever it might take to help with this practice change. I would say, don't just believe me, read the paper. Think for yourself. Figure this out for yourself. It's on you to make sure you're doing the right thing for your patients and treat them with kindness and compassion and respect.
I'm going to ask two of you one last question. We're going to go into the betting world. Give me the over-under on how many years it'll take before you walk into a room in NAEMSP and you ask for a raise of hands where more than 50% of the people have stopped using C-collars. Over-under number of years.
Under
For
5.
who to stop using them? I'm sorry.
5. For half of a room of EMS of a room in NAEMSP at the opening ceremonies, when you say who's using C-collars or who's not using C-collars, for over 50% to say I'm not. What's the over under? Michael says 5 years. I'm holding you to this. I'm going to put it on my calendar.
I'm gonna go with 6.
I'm gonna say 10. I'm gonna say 10. It's an unfortunate 10 because if Michael, you started the backboards when?
2012.
2012. How long did that take until the majority?
Okay, well, true that. In Maryland, you can still find them.
Right. So, well, listen, we all applaud what you've done. We've all learned so much today. I have a feeling this may be one of the most watched webinars we've ever done. So thank you guys for all the work you've put in. A lot of people don't understand that, like, this is not just a document. This is hours and hours. It's a labor of love. It's I know, Michael, for you, this has been a passion for you your entire career. So to see it come to fruition must be a great honor for you. We appreciate your leadership. Ben, you're, a Florida guy leading the way, and I think this is going to make a big impact in our state. So to everybody, thanks for showing up today. We hope to see you at the conference. For those of you who are not members of the NAEMSP, go get a freaking membership. Come have a free dinner, for God's sakes. And we'll see you in Tampa in January. Thanks, everybody. And head over to Dr. Pepe's webinar before he gets upset with me that I'm stealing his group. The link to Pepe's webinar is up there, but I will put it back in the chat. Thanks,
Thank
everybody.
you again, Peter.
You got it, guys.
Thank
Thank
you.
you. Let me link it right here again in case people don't have it. All right. There it is. All right. Awesome. Thank you, everybody.